Hi, and welcome to the Plastic, Reconstructive and Cosmetic Surgery Journal Club for February 6th, 2013. My name's Damien Marucci. I'm a plastic and reconstructive surgeon. This is Dr. Shagun Agrawal, who's one of the accredited plastic surgery trainees currently working at the Children's Hospital at Westmead. As usual, we did 4 papers today, including a classic paper, and the first paper we did was the prospective multi-centre trial of modified retrograde percutaneous intramedullary Kirschner-Weil fixation for displaced metacarpal neck and shaft fractures. This was published in the, I think it was the March 2012 PRS, and it's from Korea. Now, what in a nutshell was this paper about, Shagun?
Well, this unit basically had focused on a multi-centre trial, and they were trying to describe a new technique of a retrograde K-wire insertion for their metacarpal fractures. And they described multiple K-wires that were inserted retrogradely, then pulled out through the proximal wrist or just beyond the wrist joint. And they used usually about 2 K-wires, and they used that for about 105 patients. And they showed pretty good results functionally and time for union of the bone. So pretty good results for a technique that we probably don't use that often in Sydney.
What did people think about the paper?
Overall we thought it was a good paper, described the things well. I guess some of the criticisms were that people said, well, you do the retrograde K-wire, you essentially passing through a joint, and then when you come out proximally, you've basically had a K-wire gone through a joint and you're leaving that in there for about 5 to 6 weeks. Seemed like a long time. Yeah. The second thing people said was, well, the distal fragment, if it's quite small, how much purchase are you really getting? Yep. So that was an interesting comment. Yeah. And I guess otherwise it seemed like it was a good technique. Yeah. Good results. Yeah.
Generally speaking, the dedicated hand surgeons are particularly keen on open reduction and internal fixation for all types of fractures, in particular for metacarpal fractures, whereas K-wire fixation in many circles is seen as the lazy poor cousin. But this paper certainly had very impressive results. The early mobilisation protocol, which began very early, didn't it?
Yeah, I thought that was interesting. They started like 2 days after the operation, which was really good.
And that's certainly not the way that most units that use K-wire fixations for metacarpal fractures rehabilitate their patients. It was an interesting paper, and there was some good, robust discussion about it.
Yes. All right,
the next 2 papers had to do with fingertip injuries. The first paper was the classic paper. This is the Venkataswamy paper from PRS 1980 from Madras in India. The oblique triangular flap, a new method of repair of oblique amputations of the fingertip and thumb. And then the other paper linked to that was from PRS, again in, was that this month? PRS 2013. Yep. Looking at the treatment and outcomes of fingertip injuries at a large metropolitan public hospital out of New York, from PRS this month. So, in a nutshell, what were these 2 papers?
Well, the Venkataswamy paper is really describing a technique of fingertip reconstruction. It looked at an oblique amputation of the fingertip, and it was essentially in a flap that focused on one neurovascular bundle. So it was a neurovascular advancement flap, so to speak. And
even that's again oblique, so sort of just like an oblique unilateral neurovascular V to Y flap.
Yeah. And they really described the technique. They did say that they used it for 78 patients, but we were given details about 2. But certainly we do consider that in our armamentarium of fingertip reconstruction, so it's certainly stood the test of time. Yeah,
it was very interesting looking at it historically, because actually the discussion of the result was like, oh yeah, they all got sensation back, and all the scars healed well, and it was all sort of very general, whereas the more modern papers, I mean obviously this is now 30 years ago, whereas modern papers now we expect far more robust results reporting, and preferentially objective rather than subjective measures of outcome. Yeah. And how about the paper from New York looking at fingertip injuries?
Yeah, so I mean this paper certainly looked at a number of people, 100 patients over the beginning part of 2011, and they focused on 4 different types of injuries, which focused on some that were with bone exposed and some not, and they looked at what they did for those patients. So we got a snapshot of what New York surgeons were doing.
Yeah, and in their particular population, one of the things that made it interesting was that they have a very unreliable population, a large indigent community, who may or may not turn up for surgery should surgery be scheduled. So they looked at 100 fingertip injuries, looking at those that were managed both operatively and non-operatively, and they look at a whole lot of variables, whether the patients came to surgery or not, and the result of surgery, complications, 2-point discriminations, time to wound healing, obviously size of the defect, whether bone was involved, the pattern of injury. Yeah, it seemed like a very good prospectively collected data, which was then retrospectively analysed.
Yes. I guess really the only comments to make were that we, people were, a lot of them were treated conservatively, or really just operate on the emergency, and they ended up with good results. They were healed, good 2-point discrimination, which we thought were interesting. The size of the defects certainly were a lot larger than what we are normally taught, almost close to 2 centimetres squared, but those patients healed as well. So it was probably a good paper in that showing conservative management can work. Yeah,
including patients who had bone exposed.
Yes.
And certainly that's what I certainly always was taught in my practice, that if bone was exposed with an amputation, you should be doing some sort of local flap in order to cover the exposed bone. Whereas they had a number of patients, I think it was 24 who had bone exposed, who had non-operative management and went on to heal uneventfully. They also had a collection of patients who had bone exposed who had surgical management, who also healed uneventfully as well. But it was very interesting. One of the discussion points which was brought up was that these patients weren't randomised. So it wasn't like bone was exposed, some patients got an operation, some patients were randomised not to have an operation. The patients were either offered an operation or they weren't. Some patients who were offered an operation didn't turn up to their surgery and healed without surgery. And in many ways, that's the most interesting subgroup of patients, where there was clearly an intention to treat, which was not carried through, but healing went on despite the absence of surgery.
Yeah.
That was pretty good. Okay. So we thought that was a good paper, but if you could have a randomised trial,
yes,
especially with bone exposed, so that's certainly something which I think the vast majority of surgeons would currently think, oh, look, bone's exposed, you really need to cover it with some sort of flap. But there you go. The final one was a topic we've covered many times in Journal Club, a comprehensive algorithm for oncological maxillary reconstruction. This is from the MD Anderson Cancer Center in Houston, from PRS this year. And what was this paper about?
So this was a retrospective review of over 10 years of 15 surgeons' experience with maxillary defects at MD Anderson. And overall it was a good paper. They described 13 different types of defects and really broke that down into what they did for each defect and their results. The results were certainly quite good, or at least comparable to other head and neck reconstructions, but they gave us sort of a general feel for what they can do. And I guess the standout thing was that unlike other head and neck things, you can use an obturator for certain defects.
Yes.
And I guess the other thing to think about is what's happening to the orbit and whether or not you're going to reconstruct the dentition, which is really the key things to selecting your flaps.
Yeah. In terms of they divided maxillectomy defects into ones which were posterior to the canine tooth, and they made the point that, and previous researchers brought this out by OK, I'm not sure how that's pronounced, OKAY is the author, that if the canine is preserved, you can use a denture which can be attached to the remaining dentition for dental rehabilitation, whether it's part of an obturator or not, or just over the top of a soft tissue flap. If, however, the canine is not preserved, what they recommended was a bony flap, just so you would then have the potential for dental rehabilitation with an osseointegrated implant. They made the point that if an implant is to be put in to the bone flap, it should be done prior to the commencement of radiotherapy, which really only gives you a window of a couple of weeks. Most of the time for these patients, they do like to commence radiotherapy as soon as possible following the completion of surgery. The only other option would be to wait for the completion of surgery and then do your bony flap. But obviously, no one really likes operating on irradiated fields if you can possibly avoid it. Did anyone else have anything else to say about that?
I guess people just said that I guess we have had a few papers on different classifications, so this was another different classification, I guess. But certainly one that was easy to understand and follow. You may or may not choose to use their classification, but I thought it was nice how they separate into nice, discrete things that you could focus on. And I guess that's
that is about it.
That's about it.
Well, that is the end of another video discussion of the Plastic Reconstructive and Cosmetic Surgery Journal Club. Shagun did a fantastic job. If you were there, you'd know that. So for those of you who weren't there, thank you for listening. Okay, bye.